Hello and welcome to today's Health Equity Roundtable series. My name is Sarah Maines and I'm the Liver Cancers Program Director at Global Liver Institute that we also refer to as GLI. Thank you so much for being here. Once again, we're focusing on raising awareness about liver cancer through our annual October is for Livers campaign. And this October, GLI is driving equity by connecting with diverse communities around the world and continues to push boundaries among the liver cancers community. Today, we continue our series of health equity roundtable conversations to discuss challenges and potential solutions to tackle liver cancer together. And in this episode, we are joined by leading clinical and research experts from the Veterans Administration to talk about veterans and liver health and liver cancer. Please join me today in welcoming Dr. Jacqueline O'Leary, the Chief of Hepatology at North Texas VA Healthcare Systems, with specialties in gastroenterology and liver transplant hepatology. And providing insights to our conversation will also be Dr. Brian Davis, Medical Director of Gastroenterology and Liver Transplant at Richmond VA Medical Center. And finally, we are joined by Dr. Ho-Chung Gillis, Clinical Program Director of Gastroenterology and Hepatology, Liver Transplant Program Director, and Associate Director of GI Research for Richmond Institute of Veterans Research, providing a specialty focus in GI, hepatology, and liver transplant hepatology. Thank you to the three of you for being here today. We really appreciate this. And I know we're going to be talking about all things health equity today. And before we dive into that topic and talking about health equity in the VA administration, I would love to hear about the personal journey that you have, what inspired you to specialize in liver health, and what motivates you to work in the veterans community. Dr. O'Leary, welcome. I'd love for you to start.
Well, thank you so much, Sarah. It's certainly a great honor and privilege to be here with you and my two honored colleagues to talk about such important things that are going on with liver health. I do want to acknowledge that I am speaking as a physician, but in my personal opinions, and they don't represent that necessarily of the VA as a whole. And so that is what I will be doing today with great enthusiasm. I went into liver health because I love having long-term relationships with patients. I also like taking care of very sick patients. But my original focus was actually oncology. And what made me very sad in so many aspects of oncology was that when patients got very sick, oftentimes there was no hope at the end and they would pass. However, when liver patients get sick, there is that miracle that you can offer them many times of liver transplantation, and that opportunity for new life and new hope through transplant really was something that drew me very strongly to liver health. The reason why I have focused my attentions now in the last 8 years at the VA is because so many uh, providers in outpatient clinical care in private practice have to prioritize quantity over quality of care, as well as focusing on now as opposed to late investing in later. And I think what the VA has done really well at is focusing on quality over RVUs or quantity. And I think that's an exciting aspect that we do well through managing many patients on dashboards, which we'll get into later, as well as being able to focus on later as opposed to not just now, because a patient in outpatient that isn't a veteran may be on a different insurance next year. And so there's a big focus on only thinking about what they have to give them now, as opposed to investing in the future. A veteran will always be a veteran. So having that focus on now and the future allows us to focus more on health and preventing things that may be cheaper that in the long run and better for the patients than just focusing on now. So those are my main answers. Thank you so much.
I love that. And what a great combination to not just focus on now and have such a great long term plan. So thank you. I can hear your passion, and we're really glad that you're here. Dr. Gillis, welcome. I would love to hear about your journey and what led you to where you are today.
Well, thank you again. Thank you for the opportunity. And like Dr. Alir and Dr. Davis, my opinions are really just my opinions only, and not really representative of the U.S. government. But my journey within the VA system has been long. I've been here for 25 years. When I was in my nurse practitioner program in Richmond, I actually did clinical rotations at the VA. I found that the veteran population was so unique, and I really loved working with veterans. They made the ultimate sacrifice, and to give us the freedoms that we exercise today. And so this population really called to me. And although I started out in surgery, I was recruited to join hepatology and start initially the viral hepatitis program. And this is a long time ago when it was hepatitis C. And it was disproportionately affecting veterans just because there were a lot of, mass vaccinations and, a lot of mental health disorders and PTSD after Vietnam era, especially. And so we had a disproportionate number of veterans with hepatitis C, and the treatment options were quite, not successful and riddled with lots of side effects. So I really had a great opportunity to build our research department because that was really what was driving, hepatitis C therapy. And then I went into, naturally evolved into general hepatology and advanced liver disease. And then had the opportunity to build our liver transplant program. We're one of 7 VA transplant centers that offer liver transplantation, either in-house or a shared model with academic affiliates. And we are affiliated with Virginia Commonwealth University. And one of the things that, the VA has allowed me is to be innovative, right? And reach people that we historically could not reach, because there was a lot of geographic disparities in liver care and liver transplantation. Because we have veterans that lived all over the place, but they may not have, connections to specialty care. And it really, the innovative ways that, to reaching people using telehealth and remote monitoring has really allowed us to reach more people than in our geographic catchment, and also patients that are referred to us from all over the country. So I think that, my experience is that, why I've stayed in the VA, because one, because I love the veterans, but also, my passion is to offer, remote care or remote monitoring. And it's one of the reasons that we developed a virtual liver tumor board, to help other centers that don't have the specialty knowledge or access, so that we can, intervene early in vets that have liver cancer. So that's just my journey. And, I'm really proud to serve our nation.
Thank you so much. And love too that you noted rural health. That's a conversation that we're talking about this month on health equity and the disparities that are associated with rural healthcare needs, and especially for the VA population. So thank you for making that point too. Dr. Davis, welcome. We're really glad to have you today too.
Glad to be here.
Thanks for joining us.
Yeah, so I've always enjoyed rotating through the VA since medical school, residency, and fellowship, and was excited for the opportunity to join the Richmond VA liver transplant program. And like Dr. O'Leary mentioned, patients with liver disease are often the sickest in the hospital. And for now, we finally have tools that can really help them and change their disease course. And we'll probably get into this, but one of the key things to understand about liver cancer is that it's really a silent disease, right? You don't have any nerves in your liver, you don't feel things growing. And so to have a conversation to do a liver transplant surgery, which is clearly the best outcome in select patients with cancer, that takes time. Now, I can't have this conversation in 10 minutes, 15 minutes, 30 minutes. And so working in the VA allows me to have these in-depth conversations to explain to vets and their caregivers why you're here, why we're talking about something that's a major operation, that you're not having any symptoms, that you feel fine. Why do I need to have this huge surgery? And so being able to have the time and space to do that and develop a program here has been really rewarding.
Thank you very much. Appreciate that. And I'm excited now as we dive into more things related to health equity. Dr. Davis, you actually have our first question for the roundtable. Would like to talk about how studies indicate that U.S. veterans are 5 times more likely to develop HCC, hepatocellular carcinoma, compared to the general population. Wondering if you can elaborate on the specific risk factors that veterans face or face more of, and then how these contribute to the increased incidence of liver cancer that you're seeing.
Sure. So the VA has mostly cured hepatitis C, so viral hepatitis C, which we know is a big risk factor for liver cancer. But we still see this where we cure hepatitis C and then they get lost to follow up and they come back with the cancer 5 or 10 years later. So it's important to still get screening, even though we don't treat much active hepatitis C anymore. But there are also very high rates of alcohol-related liver disease and non-alcohol or metabolic-associated hepatitis, which also increases the risk of liver cancer. And so we also screen pretty well for liver cancer compared to community, so we pick up cancer as well. So those are really the main 3 diseases that we see as a cause for liver cancer.
And any chance, I know you mentioned the hepatitis C, that can almost be eradicated, and certainly there's a cure from that standpoint. Are there other risk factors with veterans that you see make them more likely?
I don't know if specifically, I mean, Dr. Leary or Ho-Chung can elaborate, but I mean, often, vets come from areas of more stress, right? So I'm very interested in alcohol. So alcohol is a big problem in the military. I mean, it goes back to Roman times. I mean, they used alcohol to fight for wars, and so that's a big problem. We have a big issue with alcohol use disorder, and so we have lots of tools to address that. And then the metabolic risk factors as well: high blood pressure, diabetes, obesity. There's a large percentage of that in the vets population as well.
I think also it's important to note with veterans, and we just don't know enough of it, but about the toxic exposures that they encounter, like at, Camp Lejeune and other things that burn pits now. And I think there are just a lot of exposures that we don't really understand, but we do know that our patients, that have, liver disease and liver cancer, tend to be, have histories of toxic exposure. So I think that we are trying to learn more about how that is interconnected, with chronic liver disease. We know that from Agent Orange, but there are so many other things that our veterans have been exposed to that we do not yet know, the chicken versus the egg, and contributors to, to their liver disease and cancer.
And one of the things, especially in Vietnam, we did not have a test for hepatitis C at the time. So about 1 in 6 units of blood was infected with hepatitis C. And so people who ended up getting even plasma or blood or other types of blood products did have a very high risk of contracting it through the military, in addition to these vaccine programs and then the rampant drug use that was really used for self-treatment of PTSD in combination with alcohol use disorder. And so there was a higher risk for progression to cirrhosis in especially males who had hepatitis C, and worse if they were combining it with alcohol.
And exactly, I mean, we are, a health system that serves, over 90% men, right? So, so that is also drivers, and a risk factor as far as when you're comparing, cancer rates between men and women. But the other thing too is that veterans sometimes, especially with the metabolic dysfunction, not only their obesity, but also their diabetes. But, there are a lot of injuries that they sustain during, military service, which also make it difficult to, optimize, be active and, participate in ways to reduce their metabolic risk. But I think that there are veteran specific things that, definitely have contributed. And what's scary is that, there's such a high prevalence of, metabolic dysfunction in the VA system too, but we are starting to see a lot more cancers that are not traditionally cirrhotic, on imaging, or they aren't known to be cirrhotic. So like that silent disease that Dr. Davis was talking about. And we're seeing more and more of that in cases in our liver tumor board. And those that, are not overtly cirrhotic, because that's the primary, driver for in greater than 90% of the cases for HCC. But it just, we're starting to see a lot in that non-cirrhotic setting for these liver cancers, where it's difficult to, apply like the LIRADS criteria, making a diagnostic diagnosis, but in surprise that, when biopsy after biopsy comes back liver cancer.
Well, and to your point, Dr. O'Leary, I'd love to talk about screening to ensure early detection. Given the elevated risk factors of liver cancers among veterans, how do you approach screening to ensure early detection? And can you explain the screening strategies on how they might differ between community-based VA facilities or larger hospitals, and what impact do you see on that for outcomes?
Yeah, I think I have like really 3 points here. The first being that the standard of care nationally and internationally for screening for liver cancer is in patients diagnosed with cirrhosis or hepatitis B. They do need liver cancer screening with an ultrasound and a blood test called an alpha-fetoprotein every 6 months. Where I think the VA has been outstanding in this is that we have a dashboard that gives you all of the names of the patients who have an ICD-9 or 10 code of cirrhosis and whether they are up to date with their cancer screening or not. So you can look and see in your VISN or your center who is up to date, and more importantly, who isn't up to date. And then have an LVN or nurse or even a scheduler put those people into clinic or have them called and get them up to date. And so, especially in larger centers in the VA with more resources, the screening rate is very good because we are managing these dashboards, and this results definitely in better outcomes because we find cancers smaller when they're treatable and when they're transplantable. And it results in spectacular outcomes for patients, caregivers, and it's cheaper. So it's better for everybody. Our biggest challenge is finding all the patients with cirrhosis. So we used to know, in general, who had cirrhosis and who didn't because so many of them had viral disease. Now, a lot of them have liver function tests in the normal range, which isn't always normal. And they should be being screened with a simple test called a FIB4, which you can calculate online. It just takes the age, platelets, AST, and ALT to say if you have a risk factor. And then, whether or not you need to be just tested next year if you're in low risk, whether you might need an additional test like a FibroScan or something to better stage you, or whether or not you're at high risk and you need to actually see a specialist like a gastroenterologist or hepatologist. And I think that's where we need the biggest help, is getting that message out to the primary care doctors that they have to screen all their patients every year with the FIB4. It is essential because we aren't going to screen people for liver cancer unless we know they have cirrhosis, because that's where it's cost effective. Where it is different between large centers and smaller centers with the VA, to answer that question specifically, is that in large centers such as myself and my colleagues here, we have access to clinical trials, which are like the next level of screening, which is really exciting. Like the VA has a VA cooperative study looking at abbreviated MRI, to see if it's cost effective within the VA setting. These are exciting opportunities that keep people on time screening, and they have access to even better ways of screening. And so those kind of exceptional opportunities are available at large centers and not as available at smaller centers.
And then is that something that you try to work with patients oftentimes who are at smaller centers to see if they have access and ability to go to larger centers? Or is that where kind of multidisciplinary communication comes into play too?
Right. So unfortunately, right now, the vast majority of our research patients do come from our center and our catchment area. Although the VA does work on sort of a spoke and wheel system. So for example, here in North Texas, we have our main hub, which is the North Texas VA, which is in Dallas. But our spokes on that are further out, like Tyler and Bonham. These are smaller areas, and we do offer to our smaller area centers that are in our spoke and wheel. And I'm sure that's the same, in Richmond, where they offer it sort of to a larger area around them. It sounds like they actually offer it even more broadly with their tumor board, which is spectacular. And that's so important, because having your case presented at a multidisciplinary tumor board has an impact on survival, a big one. So it's fantastic that that's being, offered out to smaller areas.
Absolutely agree. And I think that we'll be diving more into that a little later. But no, that has such a profound and lasting impact on being able to connect with other colleagues and providing that superior care and kind of connecting those points to the patients. So glad to hear about that. Ho Chung, curious for you, specific to managing care, that can be particularly challenging for veterans facing barriers to access. So how do you ensure that veterans with complex liver cancer receive that coordinated and timely care in different VA systems? And what about specific programs or initiatives that you see effectively improve those outcomes?
That's really a great question. I think that a lot of things that Dr. O'Leary says, the VA has, great tools and also clinical decision support tools that are embedded in our electronic medical record that clinicians can use. As she was mentioning, like the FIB-4, like in Richmond, we have an automatic calculation but we still do need other, providers to, again, help us identify, because we don't know these people exist unless they're referred to us or that they're known to us. But so we do, use and try to make sure that we have, appropriate cancer screening in our cirrhotic patients. One of the things that we've done in our advanced liver disease clinic is that oftentimes we coordinate them getting their ultrasound and then also their clinic appointments on the same day. So we know that our success rates are better when we actually meet the veteran, and provide, care. If you make it easier for them and have improved access, we've been really successful, and I really appreciate our radiology colleagues, in accommodating that. Another way that we have promoted access is that, again, we have this model called SCAN ECHO hepatology. And ECHO stands for Extension of Healthcare Outcomes. And this was also a model that was used in the hepatitis C days. It was Sanjeev Arroyo that actually developed this model. And, again, the more that you train, the more you make aware, they become force multipliers. And so what I did was, I set up what they call interfacility pathways, so that you can, consult us through a formal mechanism. It's tracked. And then I can also see make sure that, we try to see all new cancer cases within a week. in our liver tumor board, right? Because time is of the essence, right, when it comes to a cancer diagnosis. So we are very fortunate to have transplant surgery. We have the entire spectrum of multidisciplinary specialists, including medical oncology, radiation oncology, surgical oncology, transplant surgery. We obviously have our medical folks, and we actually have our pathologists. And so we actually have, more than 40 participants because we made it easier. We used to cram into like a conference room, but I think what COVID-19 taught us is that sometimes virtual formats, are superior, right? And so the other opportunity that we were able to do that, being a virtual platform and also being a largest integrated healthcare system, we don't have like the barriers for like, if I practice in Virginia, I can't see a patient in West Virginia or whatever, right? So the VA system kind of transcends, multiple geographic boundaries. So what I've also asked other providers at other smaller VA facilities is to attend our liver tumor board so that at least they can learn, right? Learn, the nuances. And also make sure that people know what the treatment options are available, but also what's available in Richmond so that we can help them, because, there's been a lot of delays in community care. There's a lot of fragmentation because, we know that veterans want their care closer to them, but it's not always faster and it's not always better. And I get really frustrated when, community care bounces people around. And so I think that, one of the things that the VA is really good is coordinated integrated care, and we could do that quickly. And so one of the things that we've had to do is create those mechanisms so it's easy for, other healthcare specialists and other facilities, to consult us, and so that we can give them very timely and, and access and improve access to their care. So these are the things that, we've worked on to improve, access, but also to, again, be that force multiplier and teach them, but at least know how they can navigate somebody, for the next time. And so that, that makes them and enables them to be a better clinician.
No, I love that. That's so important. And the VA system does that so well. And like you said, you have a large system that can all talk to each other and work with each other across different states, and how important that is for those outcomes. Dr. O'Leary, back to you. As we discuss barriers to treatment, many veterans receive care at smaller VA facilities that lack specialized services, especially like liver transplantation, requiring them to travel further for their treatment. So given the limited number of VA transplant centers, I think we said that there are 7. Did I remember that correctly? How do vets navigate access to those services despite those geographic challenges? Are there support services available to them? What does financial help look like? Could you talk a little bit more about what you see?
Sure, and I will end up handing it back over to Dr. Davis to get his input as well, as a medical director of transplant of one of the 7 important and high quality centers within the VA. But the bottom line is that still the patient does get evaluated for transplant at their home center, and then that evaluation is sent to a referring transplant center through the VA, like Richmond, and the case is reviewed, and they determine whether or not the patient should come for further evaluation at their local center. A lot of times that is a yes, and so they're very open to hearing from us, taking our calls, do a great job of listening. The other thing is that for patients that cannot travel, there is the Mission Act, which does allow us to refer to a local center, and that is closer to home if you are more than 100 miles from your closest VA transplant center. However, a lot of times patients do prefer to go to the VA because they feel at home within a VA center. There are going to be no copays. They also have that camaraderie with the other veterans, just like Dr. Davis said. There you have more time to spend with the veterans, so they're going to have more time with the provider, which is always a benefit. And then also everything is within the medical record that everybody can see. So all the providers know exactly what's going on, which is in their long-term benefit. One of the other nice things that happened on the Mission Act was that living donor liver transplant was also covered. So not only the coverage of the cost of the transplant for the patient, but also the cost of the donor is covered, which is also nice. But I think there are still struggles with getting the smaller centers to do the transplant evaluation, especially when there is no hepatologist, but even worse when there's no gastroenterologist at the local center.
Right.
Dr.
So
Davis, anything to add to that
yeah,
too?
yeah. So there are 7 VA transplant centers, but every VA has a transplant coordinator or champion. Okay, so some of them have more experience than others, and so we have developed a triage system where as long as they reach out to me and give me very basic information, we can kind of take it from there. And we do a lot of telemedicine. Like today, I saw 2 post liver cancer transplant patients from South Carolina, from Florida, from North Carolina. I mean, we have patients on the list from Texas, New Mexico, all over the country. And with telemedicine and integrated network, I can easily look at labs. I can review images. The coordinators at the local VA, they can put orders in for me. And so we have a very collaborative relationship. So as long as I know about the case, we can usually get involved early and kind of take it from there.
Yeah, I just have a couple of things to add. I think that the veterans have enhanced benefits when they go through the VA Transplant Center. They get all transportation. You're removing the geography out of the equation by, I mean, there are some social barriers, right? Some people can't stay in Richmond for months or whatever, but the VA health system is the only one that will provide lodging, that will provide, transportation to the veteran and the caregiver. Right. And then so they get lifelong immunosuppression. So we don't see the rates of rejection compared to our community partners because people have financial or other social, determinants of health, like, financial barriers. The VA really takes care of the veterans. Right. And so the other thing, too, is, which is nice, and is that the National Surgery Office expects us to see all patients within 28 days. And so we are, bound to make sure that all non-urgent evaluations we answer within 5 business days, urgent ones like emergency ones within, 48 hours. One of the things that we do in Richmond is that when we get a evaluation, it's called Tracer. This is a secured intranet where we receive, requests from like Dr. O'Leary or other centers. And then what we do is, once we deem them acceptable for further evaluation, we see these folks, via telemedicine within 28 days, right? So because a lot of people do not have their full evaluation, so that way Dr. Davis can, or our other transplant hepatologists can identify things that need to be done, or we can anticipate doing here to again make that transition seamless, right? And also again time, right? So I think that with a lot of the tools that the VA offers, it allows, veterans access. And, I think I need GLI to have, and educate folks about ways that, the resources of veterans, we try to do a good job, but, also telling them that they need to explore all options available to them, right? I mean, it's fine to be listed at a local center, but they should also consider, because of the allocation changes, where the donor hospital is not necessarily the where the transplant center is, and then that they should be able to, because the VA allows dual listing now.
Yeah,
you know
key.
And so again, it's like, educating folks that, you can not just get one lottery ticket, but you can get 2 lottery tickets, and, expand the pool where organs are coming from. And so that's, I think, what a great enhancement. The Mission Act, like Dr. O'Leary says, gives them access to living donor, which veterans didn't have access to prior to Mission. It was very difficult unless they had their own private insurance. And we actually, became a living donor site, 2 years ago. So, these are a lot of things that the VA has really, I think, improved, and also expanded benefits so that, we can increase the access to veterans.
Right. And, transplant, again, the transplant world, local doesn't always mean better. Okay. You may have a transplant center in your backyard that does 10 transplants a year, which may not be the best place to be listed, versus the VA, where we work with our academic partner that does over 200 liver transplants a year. And so you may get listed and transplanted faster, particularly for liver cancer, where we know the allocation system has a cap. And so it's a huge advantage to be dual listed, both locally and within the VA for cancer specifically.
That's a great point. Thank you for sharing that. I feel like many of our viewers today watching this aren't aware of that. And the Living Donor Act, that's such an important area that we continue to try to excel and provide education on, and truly advocate for that need, and letting people know that that certainly is an option. We've talked some about, post-transplant care, what that looks like. Ho-Chung, I'm curious to hear, when we hear from patients, sometimes post-transplantation care is overlooked in discussions. They're unaware of follow-up. You have all talked about some of the follow-up and ongoing needs that the VA system is able to provide to veterans, but can you describe what care looks like for veterans after liver transplant? What are some of the unique challenges that they face, and how do you support their long-term recovery and health? Again, we've talked about some of these things, but I think it's so important to amplify. And also love that we've talked about caregivers so far, because I do think that that's a part of this conversation with long-term recovery.
Yeah, so just like any liver transplant program, we have to require social support, right? So the caregiver is so instrumental in the success, before and after transplant. So what it looks like to us is like, so, again, we manage patients, Dr. Davis and I manage patients all over the country. One of the things that limited us was sometimes geography, because if the patient lived in, let's just say, West Haven, Connecticut, I had less than 6 hours to get this patient here, when there's an organ offer. So, and right now, and, we use air ambulance. We've been very successful. Before, and we also transplant patients from San Juan, Puerto Rico. And that's become sometimes a geographic challenge because they don't have air ambulance. So, and it exceeded the 6 mile and the 6 hour radius. So sometimes when they became like number 1 or 2 on the list, they would come up here and stay. But I'm going to tell you, the normal perfusion pumps have really changed that. And so that way we, can keep people at home. They don't have to be in Richmond. We do a lot of great wait list management. At the time of liver offer, we fly them up here. We get them ready. They're operated at our, academic university. And then when they're ready to be discharged after their surgical event, what they do is we discharge them to an outpatient setting and put them in our lodging. And then we follow them as an outpatient basis. Now, after the surgical event, if they need ongoing, intensive inpatient care, they will be transferred back to the VA, and then we will manage them, and then, try to get them to an outpatient setting, and then ultimately at their home, right? So we do a lot, most of the times they do well. They fly through, especially liver cancer patients. They have, very compensated cirrhosis. They, otherwise they wouldn't need a transplant if it wasn't for their liver cancer. So they really, they stay in the hospital for 5 days, they're discharged, they can be home in 2 to 3 weeks, right? And then And depending on where their center is, that, we can also send them, earlier, because a lot of our, centers that refer to us are also expert hepatologists. So that we're very fortunate for, for those that work in other centers. And then we can offer remote management. So what happens is they can get their labs. You remember these coordinators that Dr. Davis was talking about? They'll put in the labs, and they do that maybe like a day or two before, and then we do our virtual appointment and we monitor them, and so that they make sure that their labs and their immunosuppression is being monitored appropriately, and also all the health maintenance stuff that occurs, like that need to occur, like making sure they long-term wise that they go to dermatology and do all the health maintenance that to again improve health outcomes after transplant. So I think the VA is uniquely positioned to do a lot of remote monitoring, and with our transplant expansion, that's something that we certainly instituted in our program.
That's great. Thank you. Dr. Davis. Oh, sorry. Did you have something to say too?
I was going to say, what I tell patients is it's a lot up front. There are a lot of pills, a lot of labs, a lot of visits, but it really settles out over time. After they go back to their home VA, it's monthly labs for the first year, and then labs every 3 months. And so, there's a scientific concept called tolerance with transplanted organs, and the liver is very tolerant. And the way I explain this to patients, like if you imagine everything you eat has to be absorbed through your gut and flow through your liver. So your liver's got to be used to seeing things that are sometimes foreign. And so over time, we can wean off most of the immunosuppressions. We never totally stop them, but we can get things to a pretty stable dose to where they can have normal quality of life after the surgery fairly quickly.
Yeah, that's a great way of explaining that, and it really gives a nice visual. I know we've discussed on this conversation so far about virtual tumor boards and the importance that they play, and really how you utilize that really well in the VA system. That multidisciplinary approach certainly has been shown to significantly improve patient health outcomes through the integrated healthcare team. So Dr. Davis, I'm wondering if you could explain a little more how the VA system implements multidisciplinary liver cancer teams at really how we approach comprehensive care for veterans, and what challenges that may face working with all of the VA centers.
Yeah, well, I would say that the standard of care for liver cancer treatment in 2024 is really just to go before tumor board, right? Because there are so many different options that you really don't know what you don't know. And so if you don't know that there are newer treatment options, then you may not have access to that. And so that's why our tumor board, we have we have interventional radiology, radiation oncology, medical oncology. We even have a clinical trials nurse that is on tumor board screening for clinical trials. And so one of the key platforms that we use is because we're in the VA, we're able to do this remotely, so people can log in and very easily access the tumor board every Wednesday from 9:30 to 10:30. And so that consistency, it really helps. And we have 20 to 30 people on, including the referring centers sometimes. So now we're starting to get referring centers from Florida. They're logging on so they can actually see the scans of their patient that they sent to us. And then afterwards, they can call the patient with the recommendations, or we call the patient with the recommendations. And it's a very smooth process.
Curious, for all of you to talk about, we've said how having the virtual tumor boards enhance patients who are rural or have transportation issues if they're not rural. Have you noticed issues from rural patients having access? Like, how do you improve that when we talk about telehealth and multidisciplinary care teams? Challenges and issues that you see, outcomes that have helped with that?
Dr. O'Leary, you want
to? So I think in patients that are in rural areas, they tend to have limited access to multidisciplinary tumor boards, which is critical to improve outcomes, number one. And number two, they have limited access to more advanced therapies there are a tremendous number of therapies, and they have varying success rates. So you want to make sure that you have been evaluated and get the treatment in a timely manner that has the best chance of success. And you also want to do it while you're being considered for transplant at the same time, if you're a candidate. And so all of these are time sensitive issues. So that's why it's so important to be presented not just at a multidisciplinary tumor board, but ideally a multidisciplinary tumor board that's associated with the transplant center. And so if you are, then you're going to get the best outcomes possible. And that really is possible through the VA at places like Richmond, because they allow people from very far away to do that. And then they don't necessarily have to get, so for example, Y90 at Richmond if they're in Florida, but they might be able to get that, in an area that was more closer to home, that they developed a partnership with. So through developing a partnership with a transplant center, you can end up with better outcomes, because then they'll help teach you how to better serve your patient.
Absolutely.
Right. And we know which centers have access to Y90 and which ones don't, right? So some centers, they only have access to taste. So that's all when they see liver cancer, they just taste everything. But we know that there are certain patients that may do better with an alternative approach like Y90 or SBRT, which we have in Richmond. And so we can link the tumor board to the transplant pathway and give that access. And we may take riskier decisions if they're a transplant candidate too. Because the real problem with liver cancer these days is if you have liver cancer and decompensated cirrhosis. Lots of centers really, particularly in the community, can't really manage that. And so you need a good hepatologist that can manage the cirrhosis as well as a tumor board to manage the cancer. And then the other thing is you actually need a radiologist who's an abdominal radiology expert, that they really, because when you get into the nitty gritty, like the details of the LIRADs there are people that can miss things, and we sometimes get into disagreements with the referring center's interpretation. But at the end of the day, with liver transplant, it's our radiologists who make that call for the transplant candidacy. And so sometimes we see a spot and we say it's cancer when the referring center said it was not. We also see the reverse situation where they send us a case and they don't think it's cancer, and we tell them it is cancer. They're a transplant candidate. Or that they need to not treat this because you have to let the tumor grow to 2 centimeters before you can get the extra meld points. We've had cases of that too. So the earlier, the better. This is a very time-sensitive disease process.
Yes.
Can I interject? Oh, go ahead.
Yeah, go ahead. No, go ahead.
Oh, I wanted to interject 2 things. One is just from a quality standpoint for those people who are listening, there are 2 quality issues that really need to happen on every scan whenever you're either screening or diagnosing liver cancer. So for the MRIs, all MRIs, when you have a suspect lesion, need to be read by the LIRADS criteria. So this is a standardized criteria, which is an essential quality aspect. When it first came out, I went to my radiology department and insisted that all of them be read like that. It takes some training, but it can be done, and it's essential. The second thing is that even ultrasounds, they have a different LIRADS criteria. It's about quality, but you need to have that quality index of LIRADS. So the quality, the diagnosis of liver lesions on MRI is a LIRADS of 1, 2, 3, 4, and 5. LIRADS 5 means that you definitely have a liver cancer, but the LIRADS that is used for ultrasound is about quality. So if you get a LIRADS A, that means you had an excellent quality ultrasound. And so therefore you really can believe that you have done the best that you can do to say that the patient does not have liver cancer. If you get a LIRADS C, the quality was very, very poor. And so you essentially sort of didn't screen them. So these are 2 important quality metrics that are needed at every hospital.
Yeah. And then, from a transplant perspective, you can have a LIRADS 5 1.8 centimeter lesion. And if that gets treated, it is a cure, but then they are not eligible for extra meld points for liver transplant. And so sometimes we have to explain to patients and referring centers, yes, there's active cancer, but in order to be a potential transplant candidate, we let the tumor grow, which is a kind of unique in the field of oncology. And so that's very important that we review scans usually before they're treated, because if we see a scan after the treatment's happened and we make a different call, that may exclude the transplant pathway for that patient.
And then going back to your rule question, I think, if the patient has internet, we can see them. I mean, that's just really like that's the lowest
Or if
bar.
they have a phone, I can talk to them.
But but I think, rural people, because of, again, these barriers, and, it always goes back to geography. And, Dr. Goldberg wrote a lot about that, and was published. But the problem with the rural, folks is because they have so long to drive, they tend, and you ask me for some barriers, and they may go to a very small community care center, right? They get the imaging. That exchange of data becomes problematic, right? Because they have to either send me the CD and I have to get it uploaded, and so that could actually delay care. Right. And so, but one of the things that I love about, again, the integrated system is that majority of sites that I deal with, and there are some sites that don't, are on Medicom. And so one of the beauties about the VA is that I could push images from one center to my center and, download it into our PAC system and actually look, and view it, because we really need, the imaging to make, if we're going to make a cancer diagnosis, right? So I think that's one of the, and that also, again, speeds up, the time to decision, right? And so I think that's really important. But, when folks get, scans in the community, and then, the community care just reports it. And I don't know, I'm not going to slam the community, but, there are variances in the community, like, and they tell them, oh, you have a spot. And then, and the veterans sometimes feel like they're by themselves, like, okay, what do I do next? Right. So, this is one of the reasons why we created this, this tumor board that is just beyond Richmond, so that we can help those patients, right? And get them into a system that can, treat their cancer.
Right, because it's really important, because the VA values time. I mean, it's really hard to get a bunch of different doctors at the same time every single week. You got radiologists, oncologists, surgeons. To get them in a physical room is probably impossible, but at least a virtual room, we can do that, because we're with the VA, and people can set aside time and not feel pressure to go to the OR or go to clinic, and they can spend time for these cases.
No, thank you for mentioning that. And I know in our conversation today, we've talked about some barriers. We've talked about some gaps in care that we've seen as we end this conversation for the series today. One of the most important aspects of our campaign and having these health equity roundtable conversations is hearing from you, what are those immediate gaps or barriers that GLI or our liver health community can help do, but specifically for Global Liver Institute? Are there things that you need in terms of, education that or gaps of care with your patient population that GLI can help with, that advocacy or awareness is needed in certain spaces? I would love to kind of hear a final thought from each of you and goals or dreams that the three of you have.
So I'll go ahead and jump in, but I think that things work better when patients advocate for themselves. And I think one of the things that patients, especially veterans, don't know is the unbelievable high risk of liver disease that they have. I'm in Texas, right? 50% of all Texans have fatty liver or MASLD. That doesn't include, and it's higher risk if you incorporate all of the other liver diseases of alcohol and hepatitis C and hepatitis B. So more than 50% of the patient population at my center has liver disease. Everyone needs to be screened with a FIB4 every year. It's a simple test based on labs that they have. And if they score low, great, get it next year. If they score intermediate, they go and get a non-invasive test that is almost like a mini liver biopsy with no needles. It's kind of FibroScan or ultrasound elastography. And if they're high risk, they can get an evaluation with the provider. And this is a simple thing that I would love more veterans to be asking about every time they go to see their primary care doctor. And I think and if they have liver disease, we have so many things that we can do for them early so they don't end up with liver cancer.
Thank
That's
you.
my ask.
So important. I love that. Thank you. Ho Chang, how about you?
Well, my ask is in the same line. And because again, you can't treat if you can't identify them, right? And I think that GLI can help us really educate, primary care and other providers that are the frontline providers in recognizing liver disease early. It's, if we can get them at the patient level, then, the primary level, I think that hopefully we can identify those that are at risk. And so I think that sometimes primary care doesn't know that there's a new therapeutic, for mast cell, if they have F2 disease or higher. Things have changed. And I think a lot of them just like, well, you have fatty liver, it's okay. Because, traditionally we didn't do anything other than lifestyle modification. And so, and I think that, with therapeutics and also advancement in non-invasive testing but we just really need to educate our frontline providers about the significance and the prevalence of liver disease, and that pretty much like 1 in 3 of patients that they see are at have liver disease, right, or potential liver disease. So I think that would be, my ask. And if anyone has a veteran that needs resources, contact me because, I can help you, and get that patient engaged to where they need to go. I mean, we're a big, we are a large system, but, we are, a family. And so we can try to help navigate, these patients. So contact me anytime.
Thank you. And
Yeah,
Dr. Davis, last but not least.
I agree. I would say that the VA is actually an ideal setup for really complex care and complex coordination. We have less barriers than other places and can really take excellent care of veterans who are really sick. And I also agree that educating, just because for example, you had your Hep C cure, that doesn't necessarily mean you never need to see a liver doctor again, because there could be underlying scar tissue or fibrosis. And so the more we can educate about veterans and everyone taking care of their health, the better things that we can be, and we can prevent things too.
And we appreciate GLI advocating for the VA health system and our providers, right? I mean, so I think we do a lot of things, great and better than the community. I mean, there's always things being published that the VA outperforms, other community centers. And I really appreciate, your endorsement of, the VA system.
There are lots of veterans out there who are not engaged with the VA. I mean, that's an even more simple message. Just if you're a veteran, reach out to your local VA and try to get engaged for care.
Well, we are certainly and truly proud to be a partner and are committed to helping with education and advocacy with liver health, and in this conversation specific to liver cancer. So we will continue to do our part, take your suggestions. How do we amplify and implement these suggestions and continue to create really positive and vital change that's needed? And I thank the three of you so much for being here today and continuing to talk about health equity and the challenges that our veterans population are experiencing. And thank you for sharing your passion and insights with us today. For the viewers who are watching, if you've missed our previous roundtable discussions, you can always find those discussions on other health equity topics on our YouTube channel, as well as the upcoming October roundtable conversations that we'll have. And from a VA-related subject matter, make sure to watch our GLI Live on better HCC screening and care for veterans. Dr. Taddy and Dr. Ianu will be talking more about the HCC surveillance program that you all do so well, and continuing to talk about challenges and help with liver cancer care. And as we continue throughout the month, please be sure to follow us on social media and stay updated on our latest information. For more details on liver health and liver cancer programs, and to access other educational resources that we have, please visit both of our websites, www.globalliver.org and www.livercentral.org, or reach out to us at cancer@globalliver.com, and we will get back to you right away. Dr. O'Leary, Ho-Trung Gillis, Dr. Davis, thank you so much for being here today, and we are excited to stay in touch with the three of you and with all of you that are listening today. Thank you.
Thank you so much, Sarah.
Thank you.
Thanks for having us.